list of participants. I can see a lot of people that I know. Nice to see you, Carrick and Marius and Claire and Rudy and Ruth and Wayne and so many others. Thanks for coming. So, as many of you may or may not know, iron metabolism and iron deficiency is a topic that I'm very passionate about. And if I look at the people in the room, I think a number of you have heard me speak about this probably on a number of occasions. And I've got a few new things that I've added in. It's always difficult to know what to leave in and what to leave out because this topic is just so interesting and exciting. So I've taken some things out and I've added some things in, also to leave some interesting things for later meetings in the year. But I just want to first say a big thank you to Cheryl, who has been organizing these meetings, and Karen Fenton has been also been doing this for many, many years, working on this. So the GastroEcho platform, for those who are new, is hosted by the Gastro Foundation in association with what is called Project ECHO, based at the University of New Mexico. And every Wednesday afternoon, same time, there's a session like this, but it's not always patient blood management. That only happens every 2 months or so. And next week, for instance, will be pathology. We leave the chat open for any questions. If any of you have interesting cases, that's actually something that we really encourage, is that you bring cases to these meetings, and love to hear from you, even off the top of your head. If you've got any interesting case that you'd like to share or like to discuss, I think there's enough people, if I look at the list of participants with expertise in iron, that we should have a very, very good discussion. So without further ado, I'm going to start sharing my screen. And let's get this going. Right. So I call this topic Iron Metabolism, the Basics Revisited, which means that we will cover the basics again that I usually cover, but I'm also going to add in a few things in a different way, some new things. I hope some new things for you as well. And I've also decided this time to not organize the talk as one would usually do, like metabolism, diagnosis, etc., but to rather integrate a few things to show where they fit in, and hopefully it makes more sense this way. And I'd really like everyone's feedback at the end to see Yep, then I have a thumbs up or something. Can you all hear me and see my screen?
Yes, we can.
Fantastic. Thanks so much. Okay, so these are my disclosures potentially related to this talk. Right, so if we look at iron metabolism, especially for those who are perhaps looking for a refresher on the topic, we tend to look at it through the lens of these 7 steps. And understanding each one of these steps actually give you a very good insight and a way to approach both the diagnosis in terms of what is causing the problem, but also how you can approach it diagnostically. In other words, what tests can you do to understand what's going on better. And if we start with iron intake, it's both about the amount and the form in which you take in iron that will determine how much is absorbed. So a normal Western diet contains about 10 to 20 milligrams of iron per day in the forms of heme iron and inorganic iron. And this means that people living in low socioeconomic circumstances, like many of our patients, are at high risk of iron deficiency. It's quite amazing in the public sector where I work, or maybe it should not be so amazing or so surprising. If you start talking to people about their diets, then you really get a feel for how much people are really struggling and how expensive meat has become. So that's why I've moved that one to the top of the list, because I think we often focus on vegetarian and vegan diets, and those patients are certainly at high risk for iron deficiency. But our patients coming from poorer areas really struggle to afford red meat, which is a very important and key source of iron. We should not forget eating disorders, alcohol use, older patients, which is Dr. Claire Barrett's one of her topics that she gives a fantastic lecture on. And they've also shown, interestingly enough, that people who have recently immigrated from low-income countries, they struggle a lot. And in the Western world, they have been noted to be an at-risk group for iron deficiency specifically. Now, as the food moves through the stomach, the iron needs to be removed, and that happens by hydrochloric acid in the gastric fluid, which will take the iron out. So logically, if a patient has a form of chronic gastritis from Helicobacter pylori, atrophic gastritis, very common in the elderly, or pernicious anemia, they are going to have a decrease in acid. And of course, if you suppress acid production with antacids or proton pump inhibitors, or you take the stomach out completely, then there is going to be the same problem. Now, iron absorption being the second step here, what we should take into account is that although you take in 10 to 20 milligrams of iron per day, there's a big difference in absorption between heme iron, which is the iron we find in meat, poultry, and fish, where a large proportion is absorbed, 30%, as you can see on the screen, versus inorganic iron, which can be found also in meat, but especially in vegetables, which is very poorly absorbed. Iron is absorbed in the duodenum mainly, but also in the upper jejunum. The body has compensatory mechanisms where you can actually absorb iron as far down as the ileum in cases of severe iron deficiency, but these are the areas where most of the iron absorption would take place. Now, what is important to note is that you can't just look at a table that we often find, which tells you how much iron is in a particular foodstuff. It's critically important to know how much of that foodstuff is absorbed. And here you can see a list of examples on the left and the percentage absorption on the right. So a huge difference between vegetables and meat, for example. So I often tell, or usually tell the story, how much spinach do you therefore need for your daily needs? So we all hear about spinach because Popeye was made strong with spinach. Well, you can actually calculate it. There's 2.6 milligrams of iron per 100 grams. You absorb 1.7%. That's 0.044 milligram. If you want to achieve the daily needs of 1 to 2 milligram, you need to take in 2 to 4 kilos per day. Now, the background to this is not only the fact that that type of iron, which is tightly bound within the vegetable and is not absorbed, it's also interestingly connected to a change in the mineral content of our fruits and vegetables over the last century. And there are many sort of hypotheses of why that would be. But if you just look at the screen here, for iron alone, there's a 50% change, a 50% decrease in iron content from 1940 to 2019. And whether that's due to soil quality, fertilizer effects, or how crops are handled post-harvesting, those are all things that are considered. For instance, just for example, there are studies that have shown that if you store oranges in one of these storage areas, within a month or two, you lose up to 50% of the vitamin C. But you can see it's not just iron. copper, huge deficiencies there, magnesium, and also for sodium. Now, if you put all of these together, you can see this is the average decline in mineral content. If you combine calcium, magnesium, and iron in cabbage, lettuce, tomatoes, and spinach, it's dropped by between 80 and 90% between 1914 and 2018. One wonders how much this has changed for all the other vitamins that are in these vegetables. But just to show you that the quality of our foods is not necessarily what we might think it to be. Furthermore, one has to remember that when you take in food, the other foods that you are taking in with your iron-rich food or your iron supplements might affect the absorption of iron. So for instance, I like to think of a continental breakfast. Everything in a continental breakfast except the orange juice will decrease iron absorption, and something else which we'll come to in a moment. This is something new for this talk. But cereals containing phosphates, tannates, and phytates, anything containing calcium, including milk or calcium supplements, should not be taken with iron. Even eggs contain a protein called phosphatin in the egg yolk, and tea and coffee have tannins and polyphenols that will affect iron absorption, but not heme iron absorption. Now, the nice part is that rooibos tea does not seem to inhibit iron absorption. So what is also important is when you supplement iron in a particular patient is that you take care to see whether the particular formulation that you use should be used on an empty stomach or can be used with food. So there are supplements that are formulated and tested and can be taken even with your continental breakfast. But if you're using what we have in state or the cheaper forms of iron, anything ferrous, that should usually be taken on an empty stomach. Orange juice increases iron absorption, may also increase side effects. I can say something about that again a little bit later. So I was looking for any publications on iron absorption and rooibos tea, which is for those from other countries. Rooibos tea is a herbal tea produced in South Africa. And the question always is whether rooibos tea will affect your iron absorption. Now, this is a study done, which I think we should repeat, by Prof. Hesseling, who used to be the head of pediatrics. When he did this study in 1979, he was still a senior consultant. I was a medical student under him, and Prof. Klopper, he became head of nuclear medicine. And interestingly enough, he was also a senior consultant still at the time, but they used the nuclear medicine method to test this here. And what they basically showed, if you look at group A, the rooibos tea group, yeah, and interesting, this article is only published in Afrikaans. The abstract at least is in English, but the average absorption for the rooibos tea group was just as good as the control group, whereas for the English tea group, the Camilla sinensis, was very poor, only 1.7%. Now, the interesting thing about this is that rooibos tea also contains some vitamin C. Just a moment. Right, so the net effect of this, therefore, is that you should keep your tea and coffee for tea time unless it's rooibos tea. Of course, there can be pathological conditions that lead to poor iron absorption. Celiac disease is a classical cause where you get villous atrophy, but there are many mechanisms, interestingly enough. Reading a bit about this, there's at least 8 or 9 mechanisms by which celiac disease can cause iron deficiency. And iron deficiency anemia in celiac patients is the most common extraintestinal manifestation and seen in 80% of patients at diagnosis in lower income countries. Now, interesting point here is that many countries have compulsory food fortification or flour fortification with iron, but the gluten-free flours don't always conform to those rules. So people with celiacs have a double problem because they now take gluten-free flours that don't have any iron in it. Of course, the inflammatory bowel diseases, gastric lymphomas, which is fortunately rare, or bariatric surgery where part of the small bowel has been removed, is also going to lead to a problem. Now, it's at this point of absorption that iron homeostasis is also controlled. The body has no way of controlling iron levels other than at the point of absorption in the small bowel. You cannot upregulate your iron excretion, so it all happens here. And this is basically from a physiological point what happens. So let me just quickly take you through it. From your food, you get your iron in as ferric iron, the 3+, which at the level of the duodenal cell or intracyte is changed to Fe2+ or ferrous iron through a ferric reductase. If you remember that acronym oil RIG, oxidation is loss of an electron, reduction is gain. So in other words, a ferric, there's it, 3+. Reductase means a electron is gained. So 3+ plus 1- gives you 2+. And the ferrous is the only form in which it can be taken into the cell, apart from heme iron. And this happens through something called DMT1, divalent metal transferase 1. The divalence makes you think of the 2+ immediately. The ferrous, why does it happen at the level of the intracyte? Because ferrous iron can irritate the bowel wall, it can change your microbiota and cause a lot of other symptoms. So therefore, the body prefers, or the body is designed to do it at the level of the intracyte so you have minimal negative effects. But now you can imagine if you take iron in a ferrous form, and it's already in ferrous form when it goes into your mouth, it's going to irritate the bowel every point down from there, and therefore patients are nauseous, they have abdominal pain, they can get constipated or diarrhea. So whereas the ferric forms of iron will be okay until they reach the intracyte, where they should be changed still to Fe2+ before being absorbed. Heme iron on the right also comes into the cell through a different mechanism. And Fe2+, also ferrous iron, is released from heme iron and forms a labile iron pool. Unfortunately, because of this extra electron, this labile iron can cause a lot of damage to everything in the cell, membranes, lysosomes, DNA, RNA, mitochondria, etc. So the iron is quickly moved either into storage, ferritin in the cell, even in the duodenal intracyte, not just in the liver, or to the mitochondria for production of ATP, or it gets loaded through this iron door onto the transporter of iron called transferrin, which we'll get back to soon. But it's this door that we need to focus on, because this is where iron absorption is controlled with a key, which is called hepcidin or hepcidin. And hepcidin, you can hear from the name, hep for hepar or liver, sidin for microbicide, because before we knew that hepcidin or hepcidin was responsible for iron control, iron absorption control, it was known as a molecule that could kill bacteria. It increases in the presence of infections, particular infections that are dependent on iron, and then it also locks up all these doors so that iron cannot be available to feed all these microorganisms. So when hepcidin production, therefore, is high, this door is locked and iron absorption will be low. And the opposite happens when the production is low. In cases of iron deficiency or bleeding or things like that, the doors will be open and absorption will be increased. So important to know that this hepcidin can lock and block this door in which case iron absorption will be blocked. And this happens in infection and inflammation, but also in certain chronic diseases, such as cancer, chronic renal failure, obesity, allergies. And one of the common ones that we see these days is something like non-alcoholic fatty liver disease. And this blockage of iron absorption, not only in the bowel, but also elsewhere, as I'll show a bit later, leads to iron restriction, where iron cannot get to red cell production and leads to anemia of chronic disease. How is iron transported? Well, trans or transference, that's your transport iron. You can see the word ferrine, that relates to 3+. So when we said earlier that the iron is delivered, this Fe2+ comes through the door to be loaded onto the transporter, this little canoe. The extra electron is removed by a security guard called the Festin that stands by the door, just like a bomb would be removed from any passenger getting onto an aeroplane or something. So these little two-seater canoes are circulating through the blood and will take iron to where it is needed, and can also be used as a very useful marker to understand whether the patient is iron deficient or not. And we can measure this as either total iron binding capacity, transferrin, or transferrin saturation. Now, it's important to not get confused between transferrin and transferrin saturation. Those are two very different things and tend to move in opposite directions when a patient has iron deficiency. And I'll show you. Let's look at these 5 canoes, and let's imagine that these 5 canoes represent the total iron transport system in the body. And you've got 10 seats available. So your total transport capacity here, or total iron binding capacity, is therefore 10. Now let's put some passengers on the seat. There's some passengers. How many passengers do we have? Well, there are 4. So what is the saturation of the transport system? Well, very simple, 40%. The beauty of this is that even though this might be a simplified way of looking at it, it's really, in practice, it works very, very well. And I've not found this system to really be super confusing if you use it in clinical practice. Here's another example. The iron binding capacity is still 10. There's only 1 passenger. So you can just eyeball and say, well, there's a deficiency of passengers. No. And the saturation of the system is 10%. So clearly there are too few passengers around. In children used a lower saturation cutoff of 16% or 15%, whereas most of the current studies would use 20%. But nevertheless, even though we consider transferrin saturation less than 20% as low, on its own, it doesn't mean that there is iron deficiency in the body. It means there is perhaps a deficiency of iron on the transport system. So it could be that there's iron around, maybe it's hidden, packed away, stored in the pantry, but it's not necessarily an iron deficiency. And I'll come back to how one can look at this. The next step in our iron metabolism process is iron utilization. And as we said before, and follow the little dots from the left, the little orange dots represent the iron that goes through the enterocyte. Some of it will stay behind, as I've shown in ferritin. Then it would be loaded on the transporter kayaks, transferrin, and offloaded in the bone marrow to be used for red blood cell production. Now let's see what happens. Let's zoom in on these precursor cells in the bone marrow. So these precursor cells have receptors like little jetties where the canoes can dock. You can see the receptors here. Part of the receptor is stuck through the membrane. And interestingly enough, when you have iron deficiency, these receptors will be overexpressed because that cell will want to take up every little bit of iron that comes past. Also of note is that these receptors have the highest affinity for canoes with two passengers, also called diferric transferrin. So it prefers well-loaded boats, and empty boats will get second chance to dock. Once the iron sitting on the transferrin or the transferrin containing iron binds to the receptor, a little clathrin-coated pit will be endosomized. You've got this endosome. Hydrogen ions will be pumped into this endosome, and when it becomes acidified, the in ferritin, or go to mitochondria where they are used for energy production. And you can see if ferritin gets digested, it can form hemosiderin that one can actually stain for. And then at the end, the receptor will be recycled to the surface and go and pick up some more passengers. Now, the cool thing about this is that the extracellular portion of the receptor can actually be cleaved off and released into the serum. We call that the soluble transferrin receptor. And there's a parallel increase in the soluble component of the receptor to the number of receptors. So they remain in balance. So we said when there's iron deficiency, there will be more receptors on the surface. If there are more receptors on the surface, there's going to be more of the soluble transferrin receptor parts. Now, the clinical application of this is that this soluble transferrin receptor levels increases in iron deficiency before a patient develops anemia. So it's an early marker. And the second nice thing about it is that it's not affected by chronic inflammation. So it has been suggested as a good marker to distinguish between iron deficiency anemia and anemia of chronic disease, or even sometimes more difficult, anemia of chronic disease and anemia of chronic disease plus iron deficiency. Problem is that there's a number of other things that can increase it. Now, it's not that difficult because usually these other things may be obvious and you can get this with a good history. For instance, in regular blood donors, but that can also be because they are iron deficient, because it's very common in this group when you have lost blood, when you use erythropoietin, patients with hemolysis or ineffective erythropoiesis, as we see in thalassemia and megaloblastic anemia. The other challenges, of course, are that it's not standardized, it's not widely available, it is costly, and it might be difficult to interpret in certain conditions such as chronic kidney disease or some cancers, which can also express this transferrin receptor. Now, let's zoom in a little bit on the production of red cells. So 50% of the body iron at least are found in red blood cells. As we said, the iron is offloaded on that precursor cell in the bone marrow. This is the one that contains all the receptors. It's called a pro-erythroblast. And this one will go through a number of stages where hemoglobin will be incorporated or will be produced and iron incorporated into the hemoglobin, after which the red cells will be delivered to the circulation and go around. You can see here 200,000 million, 200 billion red cells produced per day. And there are actually some textbooks that will show you that can even be 10 times more than that. Right. So let's just look at erythropoiesis in a little bit more detail for a moment. So we've got the different steps here from the stem cell precursor through proerythroblast, and you go through all these different steps where you can see in phase 1, there's ribosome synthesis. Why? Because you need ribosomes to transcribe the proteins from RNA to make hemoglobin and so forth. So this first step, or 4 steps, takes 4 days. 1, 2, 3, 4. And then this is from the proerythroblast to the reticulocyte. And then from reticulocyte to red cell is another 2 to 4 days. 1 to 2 days in the marrow and 1 to 2 days in the blood for the reticulocyte to become a red blood cell. So in total, 6 to 8 days to produce red cells from precursor to final product. Now, I think it's helpful to understand a few elements of red cell production, which will help, especially maybe those who work in hematology or hematopathology in the audience, to make it easier to remember what happens and what all these different terms are that we use. So what happens with red cell development? Well, what is obvious first is that the cell size from stem cell to adult decreases. The size of the nucleus, you can see, decreases, and the number of cells decrease. Actually, it's actually the other way around. So from the early cells, the earliest nucleated stages are actually less than the final. So you've got fewer cells in the beginning and lots at the end. Now, the second thing to see here is that your cytoplasm also shrinks over time, and the blueness or the basophilia decreases. And this is so logical. If you look at this, in the beginning, you have lots of ribosomes, and ribosomes have a higher RNA content, so the cells will stay in blue or basophilic. As time goes on, the ribosomes and the RNA is used to make hemoglobin, which is acidophilic, and that stains pink. So the cells later on are pink. So the more hemoglobin you make, the less ribosomes you need and will have. So as you go through the steps, what's going to happen? In the beginning, things are deep blue, lots of blue ribosomes. Then with time, you're going to have a mix of ribosomes and hemoglobin. So that's called, so the first ones were basophilic. The mixed one is polychromatophilic, many colors, blue and pink mixed. Mixture of ribosomes and hemoglobin. And then at the end with the red cells, which is mainly contains hemoglobin, you now call it an orthochromatophilic normoblast. So this is just a little bit of interesting facts to understand the terminology that we get thrown to us when we read our textbooks. Now, why do we want to know about this? There's tests that we can do that can tell us what the patient's recent iron status has been. So there's something called the reticulocyte hemoglobin, which tells us about the second last cell. And we said earlier that this cell only lives for 2 to 4 days. And if that cell has enough hemoglobin, then you know it had enough iron in the last 3 to 4 days. And the cool thing about it is that on most modern instruments that we do a full blood count on, the reticulocyte hemoglobin is actually measured, although the result is not given to us unless we ask for it. And it could be an early marker of iron deficiency. And just remember that it can have different names. Reticulocyte hemoglobin content, or CHR, is the name used when you use the ADVIA platform. And reticulocyte hemoglobin equivalent, or RET-HE, is that when you use the Sysmex platform. But they tell you the same thing. So depending on your lab, you'll have either the one or the other. So just speak to to your local lab and ask them which one it is so that you can specify. Do not ask for just for a reticulocyte count, because you will not get this result. It's something different. You have to specify reticulocyte, hemoglobin content, or hemoglobin equivalent. And in my experience, because this test has not been used that widely, try to know which one your lab use and actually say CHR or RET-HE. Otherwise, I found that many times they just do a reticulocyte count if the particular person operating the machines is not aware of what you are asking. So altogether, you will end up with 250 million hemoglobin molecules for every red cell you make. And obviously, if you're iron deficient, you're not going to make hemoglobin. And then with time, the red cells will become smaller. Why? Because they don't need to be that big, because there's not that much hemoglobin in it. They will have less color, because we just heard that the hemoglobin has a certain color that comes from the hemoglobin. And if there's no hemoglobin, you don't have color. So you will have hypochromic red cells as reflected in a decreased MCH, or mean cellular hemoglobin. There could also be other tests that could help you, like a decreased ferritin or bone marrow iron stores. But you have to remember that this combination is only often found in patients with advanced iron deficiency anemia. There are stages before this advanced stage where the patient can be iron depleted but not yet be anemic, where all the red cells will appear normal. The MCV, the MCH, all of that might be normal, but the patient might be deficient in iron. So stage 1 and 2, you might not see these morphological changes. In stage 2, you might have the beginnings of anemia. Now, unfortunately, when I was a student, we learned this off the top of our head. If the MCV is less than 80, I think of iron deficiency. If it's 80 to 100, I think about anemia of chronic disease. And if it's more than 100, I think of megaloblastic anemia. Unfortunately, it is not as simple as that. There are many of cases, or 95% will probably be iron deficiency. So what does this mean? If there are stages where the patient is not yet anemic, but iron deficient, it means that a hemoglobin is not a good screening test. Because if you use the test in isolation, you will miss a lot of patients with iron deficiency. As I said before, 50% of iron is in red cells. Where's the other 50%? It's not just in red cells. So we mentioned before that iron is necessary to do other things. Myoglobin in muscle, neurotransmitters, I'm just giving examples, many more things. ATP in all cells of the body, but especially the heart. There are probably hundreds of enzymes that are dependent on iron, that if you don't have enough iron, will not function optimally. Iron is literally needed in every cell of the body, and iron deficiency, even in the absence of anemia, can present with all the symptoms of iron deficiency anemia. And we call that non-anemic iron deficiency. And this has been recognized in the last decade or so as something often missed, critically important, and something we should all be aware of. We now know that iron, for instance, plays a major role even in genetics and epigenetics, and you need this for proper translation and transcription in the DNA and RNA. Symptoms of iron deficiency. The challenge, of course, is that they are non-specific. Pica or cravings is very, very common, and I think when a patient has pica or food cravings, even excessive cravings for normal food, the most common reason is usually iron deficiency. In this particular study, it was actually quite low. The study we did way back in Bloemfontein, 2/3 of patients actually had a form of food craving or pica. Doesn't just have to be for soil or clay or dust. It can be many other things including bread, tomatoes, chocolates, etc. But these symptoms, we don't often realize or recognize that each one of these, although non-specific, iron deficiency might be the most common reason for all of them. And I usually find that patients have at least 6 or 7 of these together when they present to me. Dry skin, hair loss, and hair that break easily is extremely common. The pallor is more prominent with anemia, of course. Atrophic leucitis, often seen a little bit later. And koilonychia or spoon nails, which are classical signs, are actually absent in most patients and usually seen in patients with chronic severe iron deficiency anemia. So what does iron do? Let's quickly go to the mitochondria. So in the mitochondria, you see a number of enzymes involved in the production of ATP. Each one of these complexes that I show here, number 1 to 3, are enzymes with so-called iron-sulfur clusters, so iron-dependent, and 2 to 4 need heme iron to function properly. So basically, this whole process of ATP generation is dependent on iron-containing enzymes. Now you can imagine you need ATP to have energy, but you actually need ATP for a whole lot more. So if you are iron deficient, not only will you have mitochondrial dysfunction and impaired ATP production, you're also going to have decreased myoglobin, which means that you will have decreased oxygen storage in your muscles, which you need when you exercise. And that's why in one study, for instance, women who exercise when they're iron deficient, they become fitter and fitter to a point, and then they don't stabilize. Actually, their fitness goes down. They hit this wall and their fitness goes down. So if you're working with athletes, make sure their iron is optimized. If you're iron deficient, you also have an impaired response against reactive oxygen species. You have problems with DNA repair, replication, and cell cycling. There are lots written these days about immune effects, poor vaccine responses, etc. But now we also know dramatic effects on the neurological and hormonal systems, and also neurotransmitter production in the brain. Just for as by way of example, I'd like to show you something in the next slide. If it comes, it's now freezing. There we go. So this is an in vitro study showing control cardiomyocytes on the left, and on the right, you can see iron deficient cardiomyocytes. They basically use an iron chelator to remove the iron from these cardiac cells. And you can just, it's very obvious, the difference in contraction. So if you want to read more, that European Journal of Heart Failure article is very interesting. Now, does this mean anything in real life? Yes, it does. So for instance, if you look at patients with heart failure and reduced ejection fraction, they have found that iron deficiency alone, in other words, non-anemic iron deficiency, has a greater impact on exercise capacity than anemia from reasons other than iron deficiency. So you will be more, you'll struggle more to exercise if you are iron deficient and not anemic than when you are anemic and not iron deficiency. Iron deficient. Obviously, the combination of the two is the worst. We also now know that the same applies to hospitalization. Iron deficiency, even in the absence of anemia, is statistically significantly associated with hospitalization, whereas anemia from other causes other than iron deficiency, there's no clear correlation, at least not from this study, and the combination is, of course, the worst. And in this study, this is the prognostic implication from a mortality perspective. Again, the same thing applies. Even non-anemic iron deficiency has a 1.44 hazard ratio for mortality, even if the patient is not anemic. But when they are, that's even worse. So that's why the European heart failure guidelines now, and also the South African heart failure guidelines, show that the use of iron in the form of intravenous iron has made a dramatic difference. And there's a very recent meta-analysis that's shown a 25% improvement in hospitalization and some of these parameters when patients are treated with intravenous iron. We need to be aware in terms of this utilization phase of the times that the patients are at great risk. Infants, children, newborns, adolescents going through rapid growth spurts, but of course also pregnancy. During pregnancy, the mother needs to expand the red cell volume. The baby needs extra iron. The placenta needs iron to function. During a normal birth process without excessive bleeding, you're going to lose about 200 milligrams of iron. Plus, there's the iron lost 1 milligram per day from the skin and the urine, etc. So that's about 1290. But because the mother is not menstruating, she's also going to have some savings. So you end up with about 1,000 milligrams of extra iron needed during pregnancy. But most women only have about 500 to 1,000 milligrams. So there's a lot of moments, even preconceptually, where iron status can be affected, whether it's from preceding heavy menstrual bleeding, previous pregnancies, diet, chronic inflammation in our HIV population, etc. Even smoking and obesity can affect this and can lead to problems. Iron in women have great effects not only on pregnancy, but also on sexual function and satisfaction. This is a study from Iran showing that iron deficiency, and this was for anemic patients, there was statistically significant negative effect of iron deficiency in all parameters of sexual function and satisfaction in these women. There are suggestions that there might be a dose effect. With the worse your iron status, the more likely that you might have unexplained primary or secondary or recurrent pregnancy loss. But iron deficiency in pregnancy is common, so it's important. If you think about patients who are not yet pregnant but plan to become pregnant, 40% iron deficiency. In the Western Cape, it's 56%. Pregnant women in Africa and low middle income countries, 75% already have iron deficiency anemia, not just iron deficiency, but a very large proportion, 42% in this one study, have non-anemic iron deficiency. 1/3 of patients are iron deficient postpartum. These have a range of effects on the mother. I always say the lower the mother's hemoglobin, which you're trying to optimize with your iron, the lower that HP, the closer she is to that cliff. She lives in a rural area, she's far from a hospital, she gets there with an HP of 6 or 7, she suddenly has a massive bleed. Her margin and time to get to a big place in time or to get to a blood transfusion in time is going to be limited. So get the mother as far away from that cliff as possible by optimizing her hemoglobin and making sure that she survives. It's not just that, it's also infection risk, breast milk production, postnatal depression, bonding with baby, etc. And the fatigue and forgetfulness of pregnancy is often related to iron deficiency. Also for the baby, there are many negative effects that you can see on the screen that are well known. But there also, in children born of iron deficient mothers, a range of neurocognitive consequences. This is another talk, I'm not going to spend time on it here. But these changes and problems can last up to 25 years of age in the studies we have so far, where children are dramatically affected if born from an iron deficient mother. We now also know that the timing of iron deficiency in pregnancy is related to the development of autism and even schizophrenia. And there are many interesting mechanisms. Epigenetic dysregulation from iron deficiency is one. Sleep disorders in children, movement disorders in children and adults are associated with iron deficiency, and even atopy and allergy and asthma there's an increased risk of this when children are iron deficient. How is iron recycled? Well, the red cells circulate for 120 days. After that, they're old and damaged, and they can't survive the testing in the spleen. In the spleen are macrophages, where they will have to go through small slits, be very flexible and survive. Otherwise, the macrophages will eat them. Something very new just published is this very interesting paper that shows that platelet red blood cell complexes mediate the clearance of old red blood cells. So we know that in malaria and sickle cell anemia, this is one of the mechanisms by which the sickle cells cause their problems and damage and also are removed from the circulation is by binding to platelets. They've now shown that the same thing happens with old red cells. So on the left, for instance, if you have old red cells, there's an increased affinity for platelets. The platelets bind, and you have increased phagocytosis of red cells in the spleen. If they, in a mouse model, take platelets out of the system, the red cells actually survive. The old red cells survive. There's reduced phagocytosis. And if you take the spleen out, there's also reduced clearance of these platelet red cell complexes. So just something interesting and very new that is new pathophysiology that I thought would be interesting to you. So of note is, you remember that I said in the beginning that 1 to 2 milligrams of iron is absorbed in the gut every day. So most of the daily iron actually comes from recycled iron from old red cells, 20 to 25 milligrams. And the macrophages within the spleen also has ferroportin on their surface and can deliver iron to transferrin. And that's how recycling takes place. Iron storage, that happens in the liver especially. Ferritin is in many, many cells, but especially in the liver and in muscle. And why is it important for us? Because it's useful as a diagnostic test. If it's low, it's easy. Then it tells you the tins are empty. There are not many tins, ferritins, and the patient is iron deficient. If high, you don't know. It could be that the patient has too much iron, or iron deficiency may be masked because ferritin is an acute phase protein and high in infection, inflammation, cancer, and other conditions. It's also high in liver disease, alcohol use, and iron overload. And just for interest's sake, transferrin, the transporter molecule, is a negative acute phase protein. So the opposite will happen. Some people think when the transferrin is low, the patient is iron deficient. When the transferrin is low, it usually indicates infection, inflammation, etc. It's when the transferrin saturation is low that you need to think about iron deficiency. But unfortunately, it can also be low in any of these conditions. So iron deficiency could be masked if the ferritin is high, and then you need to do other tests. Now, just a cool tip is that ferritin is a good measure of iron stores. If you take 1 nanogram per ml of ferritin, that equates to 10 milligrams of iron stores. If your patient's ferritin is 30, they have about 300 milligrams of iron stores, and you can see all the values there. But now take that back practically to the pregnant woman who needs an iron, a ferritin of extra iron of 1,000. And that's why I like serum ferritin targets of 100 in people who want to fall pregnant. So last step in iron metabolism is iron loss. This happens passively through cellular desquamation in the gut or the skin or the urinary tract, but also, of course, through menstrual blood loss. And the daily loss from desquamation is about 1 milligram per day, and from menstruation, on average, also about 1 milligram per day. So males typically absorb 1 milligram per day to compensate for the 1 milligram they lost, and women tend to absorb double that to compensate for the menstrual bleeding. So gynecological causes of bleeding is very important in iron deficiency, as 1/3 to 1/2 of all adolescents suffer from heavy menstrual bleeding, and 1/3 of them will go to their GP with this problem in any 3-year period, and 5% will even end up in ICU with severe iron deficiency anemia, not to speak of all the symptoms they have to carry around with them. And for that reason, iron deficiency has been shown to be the #1 risk factor for disability-adjusted life years lost in the age group 10 to 24. Of course, blood loss in the gut from many causes, and some of them quite ominous, such as colon cancer or gastric or small bowel cancer, very important, angiodysplasia in the older patient, peptic ulcer disease, etc., are important causes of iron deficiency, as is perioperative blood loss, hematuria, intravascular hemolysis, and endurance athletes. Do not forget medication, your anticoagulants, antiplatelet agents, nonsteroidals, herbs, and supplements. And on the right, you can see a list of a lot of supplements that can actually increase your bleeding risk, and be particularly careful about these when a patient goes for surgery. Blood donors are certainly at risk, especially women who are already predisposed, younger donors, and regular blood donors. But do not forget platelet donors. Platelet apheresis donors are usually your best donors. They have a good history of whole blood donation. They're so-called safe donors, and they start their platelet donation career often with iron deficiency. Now, to keep this short, basically, in the USA, you allow 24 platelet donations per year, which means with every platelet donation, you're going to lose a bit of red cells as well. And it equates to 5 to 6 units of whole blood that you lose per annum. So these patients need to be supported with iron supplementation. As I said earlier, iron homeostasis happens at the level of the gut, at that level of ferroportin, where hepcidin is the key. And this helps us understand, therefore, why we've got differences in testing and treatment for patients with simple iron deficiency, where all the doors represented by these circles, and you can see they sit on the macrophages, they're on the liver cells, on the enterocytes, the macrophages in the marrow as well. If the patient has simple iron deficiency, the hepcidin will be low, the doors will be open, and the tests are easy, and you can treat them with oral iron. But if the hepcidin is high, all the doors will be locked, the iron will not be able to be handed over from the macrophages to the red cell precursors, to the transport system, or from absorption, and therefore you cannot interpret your tests easily, and iron absorption will be blocked if taken orally, and this is where we need to consider alternatives. So in conclusion, there's a lot more to say about the details of diagnostics, but for time's sake, I'm going to stop here. I hope you agree that understanding iron metabolism is the foundation for understanding the symptoms and signs, the diagnostic tests, and why it is not just about anemia, but also non-anemic iron deficiency. I have more videos on my YouTube channel. It's just called Vernon Louw Med Ed. You can go there, and there's a whole lot of things, especially on iron deficiency, that you may find, I hope you'll find helpful, but also other things about hematology. Thank you. Thank you very much for your attention. I'm happy to take any questions. I think we can start with let me stop sharing, and I can see people better as well. We'll start with the chat box. Garrick says, I think a lot of times we're not aware of the decrease in iron absorption with coffee. We are always traditionally taught tea. Yes, both coffee and tea decrease iron absorption by 50%. So quite a prominent amount. Garrick says, I often get asked, how does one screen for iron deficiency without anemia as a way to prevent these patients from developing iron deficiency? Is there any advice you can give? I usually say that there is no efficient, cost-effective way to screen, but to be aware of the entity in those patients who may be at risk. I think everybody is at risk. The study done in the Western Cape on apparently healthy people showed that 56.7% of females in the study, and this came from both public and private sector, Pathcare was involved, and Tygerberg Hospital, and they showed that these apparently healthy people, more than half of women were iron deficient, and even 12% of men. So there's nothing as common as iron deficiency, I think, in your daily practice. My recommendation is to use a serum ferritin to screen, especially young women, once a year. And the simple, we didn't go into the details of the diagnostics, But a simple rule of thumb for me is a serum ferritin less than 30 is generally indicative of iron deficiency. Garrick also speaks about the iron in the heart studies. Yeah, that's a different topic, which we can focus on another day. I've got a topic just on iron in the heart. It is such a fascinating topic, and there's so much more, and it's amazing. Rudy Bosch says, I found a blue-white sclera instead of yellow-white is quite a sensitive sign to look for in iron-deficient patients. Do you see this? Rudy, you are very, what is an English word for oplettend? That's amazing. So what you get is thinning of the sclera. And when your sclera thins with iron deficiency, it can have exactly what you describe, sort of a blue whitish appearance. It's the same thing with osteogenesis imperfecta. You also get this bluish sclera from thinning of the sclera because there's decreased collagen. Now, the same type of thing is happening in iron deficiency, similar. Jenny, hello Jenny, nice to see you. Of interest is the use of iron pots. Potjie pots make a huge difference. Should we encourage the use of iron pots? Thank you, that's a great comment. I do think so. There is something they use, they call it ingots. Now I'd like to actually, maybe I can quickly show you. This is actually quite cool. Wait, now let's just see if I can stop my screen from sharing. Wait, apologies. I just want to going to quickly close my PowerPoint. There's something they call the lucky iron fish. I don't know if people have come across this. And now, I don't know, maybe they've even got a vegetarian version for this. You have to see it. It's quite interesting. But now to get my screen to move. Okay, here we go. Okay, let's just quickly go to lucky iron fish. So I've got this in my talk on iron treatment. Yeah, there we go. I'm going to quickly share my screen. I want to show you this. This is something it's quite funny. Can you see this? You see these little fish here? So they make these iron fish. You throw it into your pot in which you cook your food. Here's a better example. This thing can last for years, and it's quite cool. They now, as I said, they even make lucky iron leaves. If I can find the lucky iron leaf, right? This is the version for vegetarians. You don't like to see fish in your pot, you can put this one in. It's the same company. I've often said we should produce these in South Africa because they can be washed, put in your up in your dishwasher afterwards. It's very cool. And this is a very nice way to actually add iron to food for patients. Right, let's see what other interesting comments there are. You guys are giving me nice ideas here. Alan says most of our referrals are pregnant women. The part you presented on pregnant women was very interesting. Yes, that's another topic. I've got a specific talk just on pregnancy and iron and all the mechanisms, how it affects the development of the baby's brains and so on, Alan. Yeah, but that will be for another day. But this is my favorite topic actually, because I feel so passionate about women and babies and iron deficiency. Jenny says she's seen the pictures of iron fish being used in Eastern countries. Thanks, Belinda, for your comment. Manolia, Manolia asks about sucrosomial iron supplementation over the conventional iron supplements. Yeah, so sucrosomial iron, just for those who don't know, is an oral form of iron. It's sold as either sidral or quadrifer. You get it in a powder form, you get it in a capsule form. And this is supposed to bypass the normal iron absorption system. Sorry, guys, I've got a cold. By being absorbed in a hepcidin-independent way through the M cells in the Peyer's patches in the small bowel. Yes, it can work, but take note, it's registered as a supplement. There are other similar products, by the way, on the market as well from a different company. Not exactly the same, but it works on a similar mechanism. Also the M cells in the Peyer patches. But if you use the supplementary dose of 1 a day, it's probably only going to maintain iron levels. It's not going to treat iron deficiency. And I've often seen this treatment to fail if you only take 1 a day. So just keep that in mind. But yes, it can work. Do I recommend it over iron supplementation? Not necessarily, no. I think there are great iron supplements, even cheaper ones that I like to use. I like ferrous fumarate, for instance, because it's one of the cheapest and it's much less cheaper. No, sorry, it's much cheaper than many of the others. It is a little bit more expensive, of course, than ferrous sulfate, but it's much better tolerable. So that's what I like. There are also ferric irons, which I like because they can be taken with meals. So yeah, there are others that are also good. Rudy says in the ER, young ladies with anxiety and chest pain, low ferritin is almost always found. Rudy, that's such a good comment. We don't realize how often or how many of the psychiatric symptoms are related to iron deficiency. I've often told the story about the young lawyer who I saw, who was referred because her clever psychiatrist realized that her iron deficiency was causing her anxiety, which was not responding to her anxiety treatment, and referred her, and we diagnosed colon cancer on her. 32. Fortunately, it was early, surgically cured. But anxiety, depression, irritability is probably the most common one. Generalized mood disorders, very strongly associated and very common and seen in up to 50% of patients. Even headaches. There's one study that looked at migraine sufferers. 45% of their migraine patients had iron deficiency. Now, whether it's the cause or just an association, who knows? The point is it's common. It's common, and because the symptoms are non-specific, it's probably worth at least screening for it if a patient comes with any of these symptoms. Okay, if anybody wants to ask a question verbally, please unmute your microphone, your videos. Love to hear from you. Hi, Liz. I see Liz Botsile is here from Botswana. That's great. Hello, Louis. Nice to see you. Carol, Ruth. Yeah, lots of people I know. It's great. Fiona and Zena was there earlier. Yeah. Anybody else that want to ask a question? We are a few minutes over time. If not, it's great being with you. Thank you very much for coming and staying even longer than the time. Apologize for going over. But yeah, it was hopefully, I hope there was something new for everybody. And again, I want to say a big thank you to Cheryl and Karen and the team in the iEcho India team that helps with the technical parts, the team in iEcho New Mexico, the Gastro Foundation, everybody that's involved. We've got people here from all over sub-Saharan Africa, and really, really great to see you here. And yes, I would, those who have my cell phone number, if you can let me know whether you think the format in which I changed things around a little bit worked for you, that I would like to hear that. If it doesn't work, we've got other ideas to strengthen it. You know what? It's not about me looking good when I give a talk. I'm really trying to make this as best as I can so that we can get the message out to everybody. So if you have ideas for me, I'm always open and keen to learn from you. I've learned so much from many of you in the audience already, so I would appreciate that. Good. With that, have a wonderful evening. Thank you. Bye-bye.